patients and the relatives is, what will happen to me? What will be my future? Where shall we take the treatment, and what will happen to the treatment? Like, what will be I suffering from, the side effects of the treatment? So they usually know that the treatment of cancer is either surgical or chemotherapy or radiotherapy. So everybody has got in the back of their mind that what will happen to him or her. So it is greatly a great distress for the family and the relatives as well. So, so it is quite necessary that we should prevent and relieve the adverse effects of cancer in the palliative care caregivers, because it affects the quality of life of patients and families, and it affects treatment outcomes. Treatment outcomes in the sense that the patient may even stop taking the chemotherapy, or they may skip even the chemotherapy cycles. So we have to take very care that we give adequate attention to this nausea and vomiting. So CINV, or chemotherapy-induced nausea and vomiting, if it goes untreated, like it affects like 60 to 80% of cancer patients, and in case of radiotherapy-induced vomiting, it has been reported that 50 to 80% of patients experience this nausea and vomiting, depending upon the site and dose, etc., of the radiation. So first we'll come to chemotherapy-induced nausea and vomiting. It is of 5 different types. Acute, it occurs within the first 24 hours of institution of the chemotherapeutic agent, and it peaks in around 4 to 6 hours. And delayed, it occurs in around 2 to 3 days later. And anticipatory, this is just that the patient may be sticking to some chemotherapy protocol even then, and he has been or she has been taking chemotherapy cycles regularly. But when coming to the hospital, she may start vomiting just with the smell or some triggers. So this is called anticipatory CINV. And the next is the breakthrough. Breakthrough CINV, it may occur like within 5 days of institution of the chemotherapeutic agent, even while sticking with her, even if the patient is receiving some antiemetics, even then she or he still gets nausea and vomiting. And refractory occurs on subsequent chemotherapy cycles, even if they have stuck to a particular antiemetic regimen, still the patient experiences nausea and vomiting. So we have to know certain risk factors which may be involved in this CINV. It is found that female genders, it is more common, and history of emesis during pregnancy, motion sickness, and patients younger than 50 years of age are more prone to develop this CINV. And the amazing part is that if a patient is drinking like less than 5 drinks per week, it is said to be protective, because the CTZ or the chemoreceptor trigger zone center is already desensitized. So these patients who drink alcohol in minimal doses get less amount of nausea and vomiting during chemotherapy. So the classification is like it depends on what type of chemotherapeutic agents the patient may be taking. They have classified into highly emetogenic, moderate, low, or minimally emetogenic agents. So the whole treatment of nausea and vomiting revolves around this pathophysiology of how this vomiting is elicited. Like when a patient is given a chemotherapeutic agent, it goes to the bloodstream and it causes central nervous system as well as peripheral nervous system stimulation, and it goes to the bloodstream, and then it gives out a lot of toxic free radicals which acts on the enterochromaffin cells in the gut, and thereby from there is release of serotonin, and serotonin release is there, and this serotonin is a neurotransmitter which binds to some in the chemoreceptor trigger zone, and in the nucleus of Tractus solitarius, they go and bind to these 5-HT3 receptors via the vagal afferents. So this is one pathway, and other neurotransmitters are also involved, like our substance P, dopamine receptor. All these also, they cause chemoreceptor induced nausea and chemotherapy induced nausea and vomiting. So this is another schematic diagram of the whole pathway. And what drugs are used to prevent this nausea and vomiting is our 5-HT3 receptor antagonist, NK1 receptor antagonist, corticosteroids, dopamine, benzodiazepines, cannabinoids, and olanzapine. And this is olanzapine have newly been added, and cannabinoids have newly been added, and other non-pharmacological therapies are also there. Like among the 5-HT3 receptor antagonists, commonly we all know, I think, ondansetron, and like granisetron, dolisetron, these are commonly used. They are available both in IV and oral forms, and the doses are adjusted according to the acuteness or the necessity of the antiemetic guidelines. And now one new, not so new drug, but commonly used is our palonosetron, that is now available both in oral and IV forms, which is quite long acting and quite effective for this prevention of nausea and vomiting. So NK1 receptor antagonists, they are quite costly, so they are not not everybody can afford it, but these are some of them, like they are aprepitant, fosaprepitant, rolapitant, and netopitant. So this rolapitant is the newest agent, and netopitant along with palonosetron, called the NEPA, is now commonly being used for on 1-day chemotherapy for a single dose. So other agents which prevent nausea and vomiting are our steroids, like the steroids like dexamethasone. According to the high risk or moderate or low risk, they are given in, the doses are adjusted according to dose. And other agents are there, like our metoclopramide, dopamine receptor antagonist, our antipsychotic like olanzapine, cannabinoids, and benzodiazepines. What are the non-pharmacological methods which we have? We have our hypnosis, muscle relaxation, music therapy, yoga, acupressure, acupuncture, all those things also. So how to go about with this antiemetic, giving the antiemetics, is that there are certain guidelines these days which are updated yearly, like we have our MASC or European guideline, American or National Comprehensive Cancer Network, which has the latest updated guideline of 2019. Even the Nursing Society have got their own guidelines. So these guidelines are almost all like similar to each other. They have like a combination of drugs, like for acute nausea and vomiting, they have used like 3 drug combinations, and depending upon the severity of the nausea and vomiting, which is expected according to what chemotherapy is going to be used, according to that, they have formulated these like guidelines. So they are all quite similar, all of them, but the NCCN guideline, latest one, have added 4 drugs instead of 3 drugs. So special situations are there where patient may be having a high tendency of having high emetogenicity. So in that cases also, they have been using 3 drugs. And overview of delayed nausea and vomiting, here also some 2 drugs or 1 drugs have been used. And for our breakthrough chemotherapy, many places like our MASC and our ESMO guidelines have used olanzapine, and some other guidelines have used benzodiazepines. So in the breakthrough type of chemotherapy, they have given drugs which are different from the usual antiemetic guidelines. Anticipatory or this nausea and vomiting is best prevented by treating our acute nausea and vomiting. So antibiotics, even children also do suffer nausea and vomiting. Here also they have been given drugs according to the chemotherapeutic agent which has been given. So not only chemotherapy, radiotherapy-induced nausea and vomiting also causes emesis. So radiotherapy-induced nausea and vomiting, it depends on the type of radiation and the area of the and the dose of the radiation, fractionation, and the total body irradiation, and these have got higher tendency of having higher emetic levels. So they have given the drugs according to that. So my next talk is on constipation. It's quite a bit elaborate. It is 3 topics, so I'm going a bit fast. So cancer control and treatment of side effects associated with cancer treatment. Now I'm going to talk on constipation. Constipation is one major problem for terminally ill patients in palliative care. Around 35% of terminally ill patients in palliative care develop constipation. The most common cause of constipation being immobilization, poor health, low fiber diet, and patient may previously be having some pre-existing functional constipation. Other causes are the cancer treatment itself, or like our painkillers, anticholinergics, etc. So in general, what causes constipation in a normal patient also we have to take into consideration. Like patient may be in a lot of painkillers, or they may have, particularly in cancer patients, they may be taking our antiemetics like ondansetron. Even they also cause constipation. And in cancer patients in particular, patients cannot eat. So patients cannot eat, then they cannot drink also. So in that case, they may be quite dehydrated. So that may be one cause, and there may be some thyroid issues, and there may be actual lack of fiber in their diet, and they may have a high stress level, which may be leading them to have this constipation. So pathophysiology of the disease of this constipation is that you can divide it into 3 things. Like the bowels are normal. The only thing is that they have a low fiber intake, inadequate fluid, etc. And the next thing is they have some neurological disorders, endocrine disorders, or there is obstruction due to cancer itself. So we have to delineate what is the actual cause of the constipation. So it is quite a brief idea to have this Bristol stool chart just for the patient assessment, and how to ask what type of stool the patient has been passing. And the sources of fiber, it is necessary that when you ask, go for palliative care checkup, or if the patient comes to you, then it is quite natural that you ask what type of food he's eating, he can eat or not any food, or whether he is drinking adequate amount of water, and is there any fiber at all in his diet. So everything, so that you can make a conclusion that what may be the cause of that constipation. So in the cancer patient management, patients should be first informed of that cancer treatment itself, and which drugs may be causing constipation. And we need to have a regular inquiry into the bowel habits. Like once we prescribe opioids or some other drugs which may be leading to constipation, you cannot just ignore it and they taking the same dose and the same drug for a very long time. So maybe we have to change the laxatives, or we have to assess the stool frequency and consistency, and maybe we have to whether some questionnaires like whether there is discomfort during defecation, etc., whether patient is taking any exercise or not, all this, and opioid and we may have to decrease the opioid dosage and rotate the opioids even. Then how to assess this constipation? There are certain patient assessment of constipation syndromes, symptoms like our PAC-SIM, this quality of life, and these are basically questionnaires like they said that this PACSIM and the BFI is found to be the most useful tool for assessment of constipation. This BFI, it is a numerical analog scale of 0 to 100, where they have 3 questions like the ease of defecation, whether the patient has any feeling of incomplete bowel evacuation, or what the patient's judgment after he has been treated with opioids. So if the score goes to more than 30, so treatment for constipation is indicated. So 40% of constipation in palliative care, as we see, is mostly due to our opioid use. So opioid we have to always give with a laxative, and we have to ask certain questions to the patient on when they come to the palliative care clinic or when we go on home visits, whether that opioid, that same dose, is still necessary, or we can change the type of opioids at each visit. So we can have this questionnaires of their lifestyle modification, whether they are avoiding aggravating factors and taking simple laxatives, and addition of newer laxatives or opioid antagonists, example naloxone, nalozigol, or methylnaltrexone. This can also treat opioid-induced constipation. So it is necessary to have an idea of what laxatives we are using, whether they are bulk forming, stimulant, osmotic, or fecal softeners, or this constipation as such, whether it is impacted and patient is having diarrhea along with constipation. The stool may be hard there in the gut somewhere, and by the side of the stool patient is maybe having diarrhea, and in that case you may have to do a radiological evaluation also to see an impacted stool and maybe take out manually. So opioid-induced constipation, the cause mainly is due to our peripheral mu opioid receptors, which are largely so much maximally located on the mesenteric and submucosal plexus of the gut, which inhibits forward peristalsis, raises sphincter tone, and increase fluid absorption, and thereby reduce intestinal secretions. So when we give opioids, opioid rotation may be needed. Like we use, if we are using a more hydrophilic one, we may be wanting to use a more lipophilic one later. So, and we have to calculate equivalent doses of the drugs, opioids, and it has been found by studies that there is lower rate of constipation which is associated with transdermal opioids. When they use transdermal opioids, the rate of constipation is lower. And we have certain drug combinations like opioid with our opioid antagonists, and we have certain prokinetics, and like we have some newer drugs also like lubiprostone, and we have something called pamoras, which are peripherally active mu opioid receptor antagonists. They are designed to antagonize the intestinal activity of opioids, but preserving their systemic effects. They are the methylnaltrexone, nalozigol, alvimupan, nalmidimine. These are the new drugs. And another treatment of constipation is manually evacuation of the rectum sigmoid by using suppositories, enemas, and maybe irrigation also. My next talk is on pruritus. Cancer and control and treatment of cancer side effect. Another cancer side effect, that is pruritus. Cancer itself can lead to pruritus, or cancer treatment also can lead to pruritus. Both chemotherapy as well as radiotherapy can lead to pruritus. So we have to see that cancer, when there is cancer itself coming, like our Hodgkin's disease or lymphoma, leukemia, we may have this pruritus. And certain other things associated with cancer like uremia, iron deficiency, allergens, drugs, etc., these also may cause pruritus. So acute itching is usually due to hypersensitivity reactions to our chemotherapeutic agents like paclitaxel, etc. And chronic itching, it may be due to our interleukins, interferon, or growth factors, etc. And the treatment for this pruritus is just general measures like avoiding triggers like friction, and our bed linen, etc. should be comfortable. It should be made up of cotton, not that it should be synthetic and causing harm to the skin. And there should be no overheating. Vasodilators should not be used, and soap and other products that dry the skin should not be used. They should avoid hot, spicy food, alcohol, etc. And the skin can be cooled with moisturizers. And the drug treatment is usually like symptomatic, like we can give histamine, antihistamine like loratadine, or oral corticosteroids, NSAIDs, erythropoietin, cimetidine, opioid antagonists for cholestatic jaundice, and 5-HT2 receptor antagonists for cholestatic jaundice, and other drugs which may be cancer can be given for cancer-related itching. This is one reaction after radiation therapy which occurs to the skin. There can be 3 types of skin lesions, like in radiotherapy. There can be erythema, which occurs after 1 to 2 weeks of treatment. There is inflammation and tingling in the skin, and there can be dry desquamation, which occurs after 2 to 3 weeks of treatment. The skin can become hot, flaky, itchy, and they may have hot, flaky, itchy skin. And there can be moist desquamation, where there are blisters, denuded, painful areas of dermis. Treatment of dry erythema and dry desquamation is usually by aqueous moisturizing cream, which is applied according to the severity of the erythema or dry desquamation, and hydrocortisone 1% for itchy skin. And there is some intrasite gel, which is an amorphous gel which gently rehydrates necrotic tissues. This can be used. And in case of moist desquamation, the dressing has to be very carefully done. It has to be kept moist. And here we can use intrasite gel or Mipilex dressing, Mipilex dressing is a foam dressing which is silicone base and which minimizes pain and wound or skin damage. Thank you.